within Durham and Darlington CAMS, we had issues around waiting times. We have a KPI around a 9-week wait, so that means all children and young people should be seen within 9 weeks. At the point in February, we had over 900 young people waiting for a first appointment, with about 220 of them waiting over 9 weeks. We've previously done waiting time initiatives, which actually just had short-term benefits, and the impact of those waiting time initiatives is to push the referrals through. So we put a lot of resource into that front end for a short period of time to get the waiting list down, but actually those young people still wait for a second appointment, and they wait on clinicians' caseloads. So the clinicians that carry them end up with large caseloads and perhaps feeling anxious because they haven't seen those young people, which in itself leads to poor staff wellbeing. So we had high levels of sickness and poor retention at that point. So we needed to think about doing something different, really. Over the previous 2 years, there have been 2 waiting time initiatives, and neither the improvements on either occasion had been sustained. So initially afterwards you get the waiters are reduced, but actually about 3 months later they go through the roof. So we knew that we needed to think differently. So we looked at a recovery plan that kind of looked at other areas to work on, and at that point the PPCS work was being introduced. So it was an opportunity to think differently, think more long term, and rather think about pushing people through, thinking about levelling the floor, and really starting to kind of understand why the referral rates had gone up, and the implications on staff. So it gave us an opportunity really to think differently and some of the other strategies we could use to deal with that. We have no 9-week waiters, and in total we have 126 young people waiting, but all of those young people would have had a telephone assessment, so we can have assurance around risk. The other benefit is that staff retention and staff wellbeing is improved. So prior to this I had 10.1% sickness, now it's 4.5, which is the trust KPI level. So the daily leave management gave us an opportunity actually for the team managers to take responsibility of their data. So the way we work now is we use daily leave management. The team managers phone in daily. They report out on the waiters, they report out on the number of referrals, the number of assessment slots, and we triangulate all that data on a daily basis. So if we can see that referrals are going up, we need to kind of make sure that there's enough assessment slots to manage that. We also, as part of this work leading up to it, we did a lot of kind of deep dive, and myself and the service manager did a lot of caseload management using the tools from the PPCS work. And I think some people would probably say, why would you do it? And I think I would answer that by because I didn't really understand. There was a lot of rhetoric. I was told lots of things around the problems, and actually felt we need to spend some time with the primary mental health workers using the caseload management tool. And that helped us to understand actually a lot of these referrals shouldn't be coming to us, and start to think about strategies of managing that. So the key benefits are transparency, ownership, having the data there in, every day live, and being able to react to that, and resolving things at source. So linking in it with the quiz methodology, that mistake proofing, instead of me looking on IIC and suddenly seeing there was 100 people had just come in. Actually the team managers looking at that, and actually a lot of the time it was data entry errors. So they would then talk to that individual and they would have to resolve it, where previously it would probably, I would have identified it and my admin would have probably resolved it. So it just kind of pushed back a little bit, and now the team managers all understand their own data. I think initially I was probably a little bit hesitant for all, the tools look great, and they make sense. Caseload management, activity planning, breaking big teams down into small teams, that communication around huddles. I think we're within the trust, we've had lots of experience with quality improvement activity, and we see sometimes short-term improvements, and sometimes sustainability is really difficult and we lose it a little bit. So I was, kind of optimistic, but still a little bit cynical that actually how will we sustain this? How will we get everybody on board? I think time for us, we're a small directorate from a management point of view. There's myself and Gillian, and I think some of the deep dive work we really felt we needed to do, that took a lot of time out of our kind of diaries, but it was important to really understand what was happening, to start to look at some of the solutions with the team. So I think that those were the main barriers. I think team managers understanding the systems, so IIC. But again, kind of looking at some of the solution, we've been really well supported by our corporate colleagues. So whenever we came up against something that we just really didn't understand, we would pull corporate services in. And corporate services did a lot of observations for us in relation to kind of setting up the cells and the huddles. So it was certainly more objective than myself and Gillian doing that piece of work. And I think clinicians were probably more honest because it wasn't us. So I think it was, for all there were some barriers, we did manage to overcome them. So yeah, it's worked well. Go and observe it. Go and observe it. Watch it in action. I think you gain more from that, from actually looking at the documents. Really good to have a read of them and try and have an understanding, but until you actually see it in practice, you're really probably not as sure of it. And certainly that's what we did from a management point of view. We went and looked at other people's and how they were working it. So that would be the biggest thing, observe it. Biggest impact on me is transparency and really understanding what's going on in the teams, and being able to rely on kind of the team managers to resolve some of the issues, so things are not fed up as much. The cells and the huddles, because of the problems in the teams with staffing, there were lots of things escalated to the senior management team. So myself and Gillian would be quite often asked to go and visit the teams because of issues. We're breaking the teams down into cells and having huddles. There was a very clear escalation point. So they would raise something in the cells, they would put it on their boards, they would then escalate it to their senior management team within the teams. And then there's only those things that they can't resolve would be escalated up to the locality management group. So it created kind of a structure and a flow, which allowed clinicians and the senior management team to actually take some responsibility and make changes. And I don't mean that they weren't taking responsibility. I think it's something about allowing them to kind of make some decisions within the team, and not everything needs to be escalated. And for us to resolve that, actually they're very, very skilled and equipped at problem solving, and it was about us allowing them to do it. So I don't feel like that I'm having to react all of the time. I feel like the teams come up with the solutions, and I've got to say the teams have embraced this and feel empowered by that. I think for the service users, huge, because they're no longer waiting 9 weeks. All the young people are offered a telephone assessment within 24 hours of their referral coming in, or a face-to-face within 5 days. We have a single point of access, or into an appointment in their home team within 28 days. So they're getting a much better service. What it's also meant is that those people who were not suitable for our service, we can signpost on the day we receive the referral, as opposed to waiting 9 weeks to be told, actually, you need to be somewhere else, which is 9 weeks wasted, and just, a real poor service. In relation to the team, I think what it has done is freed up some capacity. The service has had an increase in referrals, but some of the work that's been done around the caseload management and the huddles and the cells is around reviewing those cases. So clear activity planning. We've seen an increase of discharges. We're starting to see caseloads coming down. We're starting to see some of the primary mental health workers whose role should be out in the schools, kind of working with education, working with other providers. They're able to do that, where previously all they were doing was assessments because they were trying to manage this kind of influx. by looking at things like our sickness and retention. I believe that staff wellbeing's improved because I'm no longer worried about any gaps in services. We're able to recruit into posts. We're not holding on to vacancies. So I think the teams probably feel that actually the pressures on them have been eased a little bit, and they also feel empowered to kind of look at some of those solutions. So staff wellbeing has certainly improved.